We'll be breaking down all major concepts covered on the exam. I'm Harvey, and we're MCCQE reviewers dedicated to helping you, the Canadian medical student, really build that clinical intuition so you feel a lot more comfortable with the exam review process.
Yeah, and I'm Donna. And just really quickly, before we dive into all the pathophysiology today, a quick reminder that this deep dive is for medical education only. It's not medical advice, so any actual clinical decisions you make should, of course, always involve a qualified healthcare provider.
Right, absolutely. So today's clinical content is drawn directly from some really reliable StatPearls articles.
Yeah.
We're focusing on the Conjunctiva, specifically looking at the articles on Conjunctivitis and Pterygium.
Which is such a high-yield topic.
Oh, massively.
Yeah.
Our mission today is to basically give you this clear, efficient, highly clinical framework for tackling ocular surface presentations on the MCCQE. We want to get you away from just like rote memorization.
Exactly, because by the end of this, you really need to be able to differentiate the completely benign stuff from the actually blinding emergencies.
Yeah, and identify those high-yield infectious and allergic causes and understand the really intricate surgical challenges of chronic conjunctival growths.
Right. And to do that, we really have to understand the underlying mechanisms. So when a patient presents to your clinic or the emergency department and their chief complaint is red eye, you are basically standing at this major clinical fork in the road.
Yeah, it's a huge divergence.
It really is. On one side, you have the self-limiting, very superficial inflammation, but on the other side, you could be dealing with a rapidly progressing, sight-threatening intraocular emergency.
And I feel like the trap for students here is just getting complacent, right?
Yeah.
I mean, conjunctivitis is the most prevalent cause of eye redness in primary care.
Oh, for sure. It's so common.
So it's incredibly easy to be sitting there reading a vignette, you see red eye,
No.
and you just immediately jump to pink eye. But how do we actually confirm conjunctivitis and rule out the emergencies using just the physical exam?
Well, it all comes down to the vascular anatomy of the eye. So the
Yeah.
conjunctiva is this transparent, lubricating mucous membrane, and it's divided into two continuous parts.
Okay.
You have the bulbar conjunctiva, which covers the actual globe of the eye itself, right over the sclera. And then you have the tarsal conjunctiva, which lines the highly vascular inner surface of the eyelids.
Right, the inside of the eyelid.
Exactly. And true conjunctivitis is fundamentally a superficial process because those two parts, the bulbar and the tarsal, are continuous. True conjunctivitis is going to present with diffuse redness affecting both of them.
Which is why I always like to think of the tarsal conjunctiva as sort of the canary in the coal mine for a benign red eye.
Oh, I like that. How so?
Well, if I pull down that lower eyelid and the tarsal conjunctiva is perfectly pink and pristine, but the bulbar conjunctiva on the globe is severely injected, that tells me the inflammation isn't superficial, it's deeper.
That is such a critical anatomical distinction. If the tarsal conjunctiva is spared, you are no longer dealing with superficial vessels. That redness you see on the globe is actually coming from the deeper ciliary vascular plexus.
Which is bad news.
Right. That deep injection points to serious intraocular pathology. You're looking at things like keratitis or severe iritis or acute angle closure glaucoma.
And the exam will usually pepper in other clinical red flags, right? To kind of steer you toward those emergent diagnoses. Like if the vignette mentions severe deep eye pain or any drop in visual acuity.
Yes, or pupil asymmetry.
Exactly. Or, slit lamp findings like a hypophenon, which is that white layer of cells in the anterior chamber, or a hyphema with blood.
Right. If you see any of that, you need to abandon the conjunctivitis algorithm entirely. Those findings mandate a rapid ophthalmology referral because the surface barrier is breached or the pathology is entirely internal.
Okay, so assuming we don't see any of those red flags, and we have confirmed this diffuse injection of both the bulbar and the tarsal conjunctiva, we've successfully diagnosed acute conjunctivitis.
We have. And the next step on the MCCQE is categorizing the etiology. The vast majority of acute cases, like 80%, are viral. And of those, adenoviruses are responsible for up to 90%.
And the classic clinical presentation for that viral conjunctivitis is a watery discharge.
Yeah.
But, let's be real, a presentation of just watery eyes is way too vague for an exam question.
Oh, way too vague. They won't just give you that. The examiners love to include preauricular lymphadenopathy to signal a viral etiology.
Little swollen lymph nodes right in front of the ear.
Exactly. And the pathophysiology behind that lymph node swelling is actually fascinating. Adenoviruses have this really strong tropism for lymphoid tissue.
Really?
Yeah, so when the virus infects the conjunctival epithelium, the local immune system drains those viral antigens directly to the preauricular Krippner nodes, and this triggers a massive localized germinal center response. Bacterial infections of the conjunctiva rarely do this, so it makes it a highly specific physical finding for viral etiologies.
That makes a lot of sense. And the timeline is also a massive clue on the exam, right?
Yeah.
Viral conjunctivitis almost always starts in one eye.
Yep, unilaterally.
And then a day or two later, the patient rubs the infected eye, touches their other eye, and basically auto-inoculates themselves. And because it's viral, the management is purely supportive.
Right, you're talking cold compresses, artificial tears, and just extensive counseling on strict hand hygiene so they don't spread it to their entire family.
Exactly. Now, bacterial conjunctivitis, on the other hand, triggers an entirely different immune response.
It does. Common adult culprits, so we're talking Staphylococcus aureus, Streptococcus pneumonia, Haemophilus influenza, they induce this really heavy neutrophilic response.
Right, so a ton of white blood cells.
A massive influx. All those white blood cells and cellular debris create that classic purulent or mucopurulent discharge.
And the really defining characteristic of that bacterial discharge is just how aggressively it reforms. Like if you wipe away a viral watery discharge, the eye stays relatively clear for a little while.
Yeah, it buys you some time.
But if you wipe away a bacterial purulent discharge, you can practically watch the pus reaccumulate at the lid margin within minutes.
It's gross, but it's very true. And it aggressively glues the eyelashes together, especially overnight. Patients always complain about waking up and not being able to open their eye.
Definitely. So for routine, mild bacterial cases in adults, what's the standard of care?
Usually it just involves using older generation topical antibiotics like polymyxin B combinations for about 5 to 7 days. They're highly effective at just clearing that local bacterial load.
Okay, so that covers viral and bacterial. Then we have allergic conjunctivitis, which shares that watery discharge of a viral infection, but it's fundamentally driven by a type 1 IgE-mediated hypersensitivity reaction.
Right, and the hallmark symptom here is intense itching. These patients often have a history of atopy, eczema or asthma, and the symptoms usually blow up seasonally in the spring and summer.
And that itching is basically driven by mast cell degranulation, right? They release histamine, which directly stimulates the nerve endings in the conjunctiva.
Exactly. So management focuses on allergen avoidance, cold compresses to cause local vasoconstriction, and topical antihistamine or mast cell stabilizers.
There is a major trap here, though, that I've seen students fall for all the time.
Oh, with the itching.
Yes. The classic teaching is always, itching equals allergies. But I've seen tricky exam questions where a patient has a mildly itchy eye and the student just immediately rules out an infection.
Yeah, relying solely on itching is a very dangerous clinical shortcut. The sources actually highlight a study showing that 58% of patients with culture-positive bacterial conjunctivitis also reported itchy eyes.
Wow, almost 60%.
Yeah, because inflammation from an infection still irritates the local nerve endings. So to differentiate them, you really have to look at the entire clinical picture. You need the character of the discharge and the presence of those preauricular lymph nodes.
That's a great point. We also need to talk about the physical changes on the conjunctiva itself.
Yeah.
Specifically how to differentiate papillae from follicles, because honestly, they sound like interchangeable terms for just bumps on the eye.
They do, but histologically they tell very different stories. So papillae are small, elevated lesions, and they contain a central vascular core.
Okay, so blood vessels in the middle.
Right. If you look closely with a slit lamp, you'll actually see a tiny red blood vessel right at the center of each bump. They form when chronic inflammation causes the conjunctival epithelium to hypertrophy, and it just pulls that central vessel up with it.
So what causes that?
You see papillae primarily in bacterial and allergic conjunctivitis, where the body is actively recruiting neutrophils or eosinophils straight from the bloodstream.
Got it. But follicles are entirely different, right? They present as these elevated yellow-white lesions, usually clustered in the inferior fornix, down in the lower cul-de-sac of the eye.
Exactly, because follicles are literally tiny hyperplastic lymphoid germinal centers.
Oh, wow.
Yeah, they're packed with B and T lymphocytes responding to an intracellular pathogen. They don't have a central vessel. The blood vessels actually sweep around the base of the follicle.
That makes sense.
And the presence of follicles strongly points toward viral infections, like adenovirus, or intracellular bacterial infections like chlamydia.
Which is a perfect transition into how specific demographics alter our standard management, because the MCCQE loves to test patient exposures that completely shift the microbial odds. Let's start with contact lens wearers.
Oh, a classic demographic.
Right. If a patient sleeps in their contacts and wakes up with a red, painful eye, we cannot just throw a generic antibiotic at them.
Absolutely not. Contact lenses create this ideal hypoxic microenvironment for Pseudomonas aeruginosa to form these really aggressive biofilms.
And Pseudomonas is terrifying for the eye.
It is. It produces powerful proteases that can rapidly melt the cornea if it causes an ulcer. You have to bypass those older generation antibiotics entirely. You need heavy empiric coverage specifically for Pseudomonas using topical fluoroquinolones like ciprofloxacin or moxifloxacin.
Okay, so always cover for Pseudomonas. Contact lens wearers are also prone to something called giant papillary conjunctivitis, or GPC. And the name sounds infectious, but the mechanism is actually purely mechanical, right?
Right, exactly. Proteins and cellular debris deposit on the surface of the contact lens over time. And every time the patient blinks, that dirty lens rubs against the upper tarsal conjunctiva.
Which just constantly irritates it.
Exactly. It triggers a mechanical and allergic immune response that results in massive papillae on the inside of the upper eyelid. The treatment there is simple. Take the lenses out and optimize lens hygiene.
Okay, moving on to another heavily tested area, the neonatal demographic. Neonatal conjunctivitis, or ophthalmia neonatorum, occurs within that first month of life, usually acquired as the infant passes through an infected birth canal.
Right. And the timeline and the severity of the discharge are really your best clues for matching the exact pathogen.
And the most terrifying one is Neisseria gonorrhea. It presents hyperacutely, usually within the first 2 to 5 days of life, with just this copious hyperpurulent discharge and severe eyelid edema.
And what makes gonorrhea so incredibly dangerous is that it's one of the very few bacteria capable of penetrating a completely intact corneal epithelium.
Wait, really? It doesn't even need a scratch?
Nope. It uses specialized pili and OPA proteins to bind tightly to the corneal cells, actively invading them and causing rapid corneal perforation.
That's horrifying.
It is. So you do not rely on topical drops for gonococcal ophthalmia neonatorum. It requires immediate systemic therapy. You need intravenous or intramuscular ceftriaxone, and it's often combined with oral azithromycin just to cover for a concurrent chlamydia infection.
Which brings up chlamydia trachomatis, which is actually the most common bacterial cause of neonatal conjunctivitis.
Right.
And that presents a bit later, usually around 5 to 14 days, with mucopurulent discharge and sometimes these bloody pseudomembranes.
Yes, and we also have to keep herpes simplex virus in mind for neonates, too. That presents with a watery discharge and often accompanying vesicular lesions on the skin or lid margins.
And those herpes viruses are equally high yield in adults, right?
Yeah.
I mean, HSV can cause acute conjunctivitis, but the real danger there is corneal involvement.
Exactly. HSV produces these classic branching dendritic ulcers on the cornea as the virus replicates within the epithelial cells.
So the clinical pearl for the exam here is that you absolutely must perform a fluorescein dye examination to visualize those dendrites anytime you even suspect HSV, even if the patient has no history of cold sores or, there's no visible skin vesicles.
Yes, definitely use the fluorescein. We also see herpes zoster ophthalmicus in older adults. This one is caused by the reactivation of the varicella zoster virus, specifically along the ophthalmic branch of the trigeminal nerve.
Ah, shingles of the eye.
Basically. They present with a painful unilateral vesicular rash that follows that exact dermatome.
Which brings us to the Hutchinson sign.
Yes. The Hutchinson sign is the presence of vesicles on the tip of the nose. Anatomically, the nasociliary branch of the trigeminal nerve innervates both the tip of the nose and the cornea.
Okay, so they're connected.
Right. So if the virus has traveled down that specific branch to cause lesions on the nose, there's a very high probability that the cornea is already involved, or at least soon will be.
Okay, that makes perfect sense. Before we move on from infectious causes entirely, we really have to touch on trachoma, because this isn't just an acute red eye, it's a leading cause of preventable blindness worldwide, caused by recurrent infections with specific serovars of chlamydia trachomatis.
Yeah, the pathophysiology of trachoma is basically a masterclass in immune-mediated damage. The initial active infections cause this intense follicular conjunctivitis, but repeated infections over years, that triggers a cell-mediated type 4 hypersensitivity response.
Right.
And that chronic inflammation leads to necrosis of those follicles, which then heal by subepithelial fibrosis.
Which brings us into the scarring stage.
Yeah.
On the exam, you might see mention of Herbert pits, which are these shallow depressions left at the limbus when those superior follicles resolve and scar down. And in severe cases, the conjunctival scarring forms thick, broad bands called art lines. This dense fibrosis physically shrinks the conjunctiva, pulling the eyelid margin inward, which is a condition called entropion.
Right.
And when that happens, the eyelashes just constantly scrape against the cornea trichiasis, eventually resulting in dense corneal opacification and blindness.
It's devastating. And speaking of severe inflammation and scarring, when patients come into the clinic with a blazing red eye, they usually just want the redness gone yesterday.
Oh yeah, they want an immediate fix.
So it is incredibly tempting to prescribe a topical steroid to quickly quiet that inflammation down.
It's tempting, sure, but it's a massive clinical trap for a primary care provider.
Yeah.
Steroids powerfully suppress the local immune response.
Yes, they do.
So if you misdiagnose, say, a herpes simplex virus conjunctivitis as just a simple adenovirus, and you prescribe a topical steroid without concurrent antiviral coverage, you basically remove the immune system's brakes.
Exactly. The virus will undergo massive, rapid replication, creating a geographic ulcer that can lead to rapid corneal melting and perforation.
So steroid use for the ocular surface should generally just be deferred to an ophthalmologist.
That is definitely a rule to live by for the MCCQE. So far, we've covered a lot of acute diffuse inflammation. But the ocular surface also suffers from chronic, localized pathologies that literally physically alter the anatomy.
Right.
And this brings us to the pterygium.
Okay, pterygium, what are we looking at here?
A pterygium is a triangular, ellastotic fibrovascular growth of subconjunctival tissue. It originates on the conjunctiva and actively encroaches onto the cornea. It almost always occurs within the palpebral fissure, which is the area exposed when the eyelids are open, usually on the medial or lateral side.
And the pathophysiology here is heavily driven by environmental exposure, right?
Yeah.
Specifically ultraviolet light.
Yes, UV light is the main culprit.
Because the border between the white sclera and the clear cornea is called the limbus. And this limbus houses the stem cells that are responsible for constantly regenerating the clear corneal epithelium. UV light acts as a mutagen here, specifically causing mutations in the p53 tumor suppressor gene within these limbal basal cells.
Exactly. Normally, p53 would force a UV-damaged cell into apoptosis. But when p53 is mutated, these damaged cells survive and they proliferate.
Oh, I see.
And the UV exposure also generates oxidative stress. This triggers the release of tissue growth factors, cytokines, and massive amounts of vascular endothelial growth factor, or VEGF.
Which drives blood vessel growth.
Right. This whole biochemical cascade leads to aggressive angiogenesis and fibroblast invasion, physically pushing the conjunctival tissue over the limbal border and onto the cornea.
Which perfectly explains the epidemiology. We see high rates of pterygium in populations living near the equator, the so-called pterygium belt. It's strongly associated with heavy, chronic UV exposure in hot, dry, and windy environments. So it's incredibly common among male outdoor workers, like farmers or fishermen.
Right. And on the exam, you have to be able to differentiate a true pterygium from other localized conjunctival growths. The most common benign distractor they'll throw at you is a pinguecula.
Ah, pinguecula.
Yeah, a pinguecula is a yellowish, elevated deposit of fat, protein, or calcium, but it sits entirely on the bulbar conjunctiva.
The analogy I always like to use to separate them is thinking about a sports field.
Okay, let's hear it.
So a pinguecula is basically a spectator sitting on the sidelines of the sclera. Like, it might look a bit ugly, but it stays in its seat.
Right.
But a pterygium is a player that has actually stepped over the limbal boundary line and is actively invading the field of the cornea.
That's a great way to picture it. The limbus is the literal barrier, and once it is breached, the diagnosis changes to pterygium. Another differential you might encounter on the exam is the pseudopterygium. This is not a primary growth, but rather an inflammatory adhesion where a fold of conjunctiva sticks to a peripheral corneal ulcer, often from like an old chemical burn or trauma.
And you can physically differentiate them in the clinic using the probe test.
Nice.
Because a pseudopterygium is essentially a bridge of scar tissue that's tethered at 2 points, so you can carefully pass a blunt probe completely beneath it.
Exactly.
But a true pterygium is firmly adherent to the underlying sclera and cornea along its entire length, so the probe will not pass.
Perfect. And particularly in older patients with a history of extensive sun exposure, you also must maintain a high index of suspicion for ocular surface squamous neoplasia, or OSSN.
Oh, that's important.
Yeah, squamous cell carcinomas can easily masquerade as a benign pterygium, and obviously misdiagnosing a malignancy can have devastating consequences.
So once we've diagnosed a true pterygium, how do we actually manage it? Because medical management with artificial tears or short courses of topical NSAIDs can, soothe the irritation and redness,
Right.
but no eye drop is going to dissolve a fibrovascular growth.
Right.
When do we actually decide to operate?
Surgery is indicated when the pterygium threatens ocular function or causes severe, intractable symptoms. The most obvious indication is decreased visual acuity, which happens when the tissue physically encroaches on the central visual axis, but it can also decrease vision indirectly by inducing astigmatism.
Right, because that fibrovascular tissue is contractile.
Hmm.
As it grows onto the cornea, it physically pulls and flattens the corneal surface horizontally, totally distorting the optics of the eye.
Exactly.
Are there other indications?
Yeah, other indications for surgery include restrictive ocular motility, where the scar tissue basically prevents the eye from moving fully laterally or medially, or just for significant patient cosmetic concerns.
But the surgical decision is not taken lightly, because pterygium surgery comes with a massive, frustrating caveat, which is recurrence.
It's the biggest issue.
The tissue aggressively wants to grow back. Historically, surgeons used a technique called simple bare sclera excision, where they simply cut the pterygium off and left the underlying sclera exposed to heal on its own.
But the recurrence rates with that bare sclera technique are just staggering, sometimes up to 89%.
That's incredibly high.
And when it comes back, it often grows faster and more aggressively, with the vast majority of recurrences happening within the first 1 to 3 months post-op.
Which seems almost counterintuitive, right? We do surgery to remove a fibrovascular growth, but the physical trauma of the surgery itself acts as a massive inflammatory trigger.
It really does.
The surgical excision causes local tissue hypoxia and this huge spike in the release of VEGF and inflammatory cytokines. So we are essentially feeding the exact biochemical pathway that caused the pterygium in the first place.
Exactly. To combat this massive fibroproliferative response, surgical techniques had to evolve. We can't just leave the sclera bare anymore. The modern standard of care involves using conjunctival autografts or limbal conjunctival autotransplants.
Right, so by harvesting healthy conjunctiva, ideally with healthy limbal stem cells from the superior aspect of the patient's own eye, and grafting it over the excision site, we achieve two things.
What are they?
First, we physically cover the bare sclera to suppress the inflammatory signal. And second, more importantly, we restore the barrier function. Those healthy stem cells reestablish the border guards at the limbus, chemically signaling the surrounding tissue to stop growing.
That's perfectly said. Surgeons also heavily rely on adjuvant therapies to chemically suppress the recurrence. Mitomycin C, or MMC, is highly effective here.
What does that do?
It's an anti-neoplastic antibiotic that acts as an alkylating agent. It cross-links DNA and inhibits DNA synthesis, completely shutting down the ability of those aggressive fibroblasts to proliferate.
Wow.
It can be applied directly to the scleral bed during surgery or used as post-operative drops, though it does carry risks of severe scleral thinning or melting if the dosing isn't absolutely perfect.
There's also a highly specialized surgical technique detailed in the literature known as PERFECT for pterygium. It stands for pterygium extended removal, followed by extended conjunctival transplantation.
Yes, the perfect technique.
The critical innovation of this technique isn't just a larger graft. It is the aggressive, extensive removal of the subconjunctival fibrovascular tissue, specifically targeting Tennant's capsule.
Right, because Tennant's capsule is a dense layer of fibrous connective tissue just beneath the conjunctiva. It basically acts as a massive reservoir for the fibroblasts that drive the recurrence.
Right.
By meticulously dissecting and removing a huge area of Tennant's layer, along with a very large autograft, the perfect technique brings the recurrence rate down to near zero. It is a much longer, more difficult surgery, but it proves that you have to eradicate the cellular source of the problem, not just the visible growth.
All right, let's pull all of this together with a rapid-fire recap of the high-yield concepts. Your first step on the MCCQE is confirming true conjunctivitis by identifying diffuse injection of both the bulbar and tarsal conjunctiva. Sparing the tarsal conjunctiva, severe pain, or vision loss means the pathology is deep think keratitis or acute glaucoma.
And then match the clinical presentation to the etiology. Watery discharge with preauricular lymph nodes points to a viral adenovirus. A rapidly reforming purulent discharge is bacterial. Intense itching with a watery discharge suggests allergic, but remember that bacteria can cause itching too.
And make sure you adjust your management based on demographics. Contact lens wearers must be covered for pseudomonas with fluoroquinolones due to biofilm risks. Neonates require rapid evaluation for Neisseria gonorrhoeae, which can aggressively penetrate an intact cornea and requires systemic ceftriaxone.
And for chronic growths, remember that a pterygium is fundamentally a UV-induced failure of the limbal stem cells. It invades the cornea, physically distinguishing it from a benign pinguecula. Because surgical trauma triggers massive VEGF release, excision requires autografts or antimetabolites like mitomycin C to prevent aggressive recurrence.
We spent a lot of time today discussing how UV radiation damages the limbal stem cells, dismantling that critical anatomical border and allowing the conjunctival tissue to aggressively invade the cornea in the form of a pterygium.
We did.
I want you to take that concept and apply it broadly. Think about what other catastrophic events like severe chemical alkali burns or thermal injuries might instantly destroy that entire ring of limbal stem cells. Without those stem cells to regenerate the clear corneal epithelium, consider how the conjunctiva would react and how that total loss of the limbal barrier would permanently and devastatingly alter the entire surface of the eye.
That's a great thought experiment. Thank you so much for joining us on this deep dive.
Keep studying hard, trust your clinical frameworks, and we will see you next time.